continuación, nos va a acompañar el doctor Daniel Lichtenstein desde Francia. El doctor Daniel Lichtenstein es médico intensivista en el Hospital Ambroise Paré de París Oeste, Francia. Es autor del protocolo Blue.
Can I interrupt you? Dr. Monares is speaking. You cannot interrupt him. Let him finish. I cannot accept.
No,
Let him finish his talk.
It's a recording. It's a recording.
Okay.
It's not a presentation, a live presentation. It's a recording, so it's okay. We just told them that we will pass the video later, or they can see it on the platform. Okay. Thank you, Dr. Lichtenstein. El doctor es médico intensivista en el Hospital Ambroise Paré de París Oeste, Francia. Es autor del protocolo Blue de la insuficiencia respiratoria aguda. También es autor del protocolo FALS de ecografía pulmonar para el tratamiento de insuficiencia circulatoria aguda. Autor del protocolo Sesame de paro cardíaco en la ecografía pulmonar en neonatos, en críticamente enfermos. Igualmente es presidente del CERF, que es el Centro de Formación Personalizada a Pie de Cama en UCI. El tema que nos va a presentar el doctor el día de hoy es ultrasonido durante el paro cardíaco, protocolo Sesame. La charla va a estar en inglés, sin embargo, ante cualquier pregunta les podemos realizar en cualquiera de los dos idiomas. Merci, doctor Lichtenstein. Pardon por la interrupción.
About the Sesame Protocol, which is ultrasound in the very critically ill patient. I'm very sorry for what happened. I like to make the things relax, and no, it does not work. So I am very sorry to look a bit upset, and I will respect the timing anyway. Sesame Protocol, an application of holistic ultrasound. Of course, I cannot have access to the slides. Okay, so my slides do not work. Okay, now they work with another function. This software is a shame. It's a disaster. Like most of the ultrasound machines dedicated to the critically ill, by the way. I will finish on time, 45 minutes. Don't worry, don't worry. So it's a great honor for me to be invited. I would have loved to meet Ecuador in real time, but it's a Zoom webinar. I have no conflict of interest. I hope I will never have any conflict of interest with nobody. So it's short lecture, not so short because 45 minutes is a great privilege, but anyway, we don't have 1 second to lose because Sesame Protocol cardiac arrest is not a joke. Okay, so I don't see the bottom of my screen, but I hope I will remember my slides. So one warning, nobody is obliged to make the Sesame Protocol. It's our way to visit a patient with a cardiac arrest. And you can read these 2 papers. I don't know if you see them with my book, which say all the things in all the details. So we will explain why we use this Sesame Protocol. I suppose that I speak with doctors who use daily critical ultrasound, whole body critical ultrasound. Now, my system again does not work. Zoom. Okay, time for making one step ahead. The soft approach to cardiac arrest. Okay, now it works. Good. It's a best of, and I have a very modern computer, especially for the webinars. So, okay, so let's not lose time. We will make a technical lecture. I hope you will find it logical. We will have to make another warning, not pleasant, maybe. Never use ultrasound in a cardiac arrest. This is the warning of SURF, our training center. If you use the traditional tools, even with that nice smile, if you do not have the small machine, the really small machine, the simple machine, with one universal probe, maybe it's better to do as do all the doctors who work without ultrasound, just because in cardiac arrest, each minute, each second generates brain damage. So I thank the scientific journals which took decisions with our submissions and since 3 decades. And this is why today all the doctors in the world have machines that serve does not advocate. I'm very sorry for this situation. So if you use the traditional tools, you will have a cumbersome machine, even if it is a laptop, with a startup time of several minutes, plenty of buttons, plenty of probes, sophisticated modes, academic approach. Your patient is dead if you use ultrasound. And well, imagination at work, I don't agree. I just think it is 30 years of delay in the history of medicine. We have never seen this anywhere in medicine. So in a cardiac resuscitation, you have to do this during hours and hours. I don't find it satisfactory. It's exhausting and disappointing. What is the Sesame Protocol? You can read sequential emergency sonography assessing mechanism or origin of severe shock of indistinct cause. We will do it step by step. Sequential, that means we have an assessment in 5 basic steps. The step 1, there is a step 0, and there is a step -1. Just rule out shockable cause, of course, first. Emergency. The word emergency is holy. It means that each second must be saved. How can we improve the parameter of the speed? Because normally you should have to bring the cumbersome machine, even a laptop, to start it on, sometimes several minutes, making all the settings, choosing which probe for this cardiac arrest, choosing which site of application, the heart, putting the traditional gel, etc., etc., etc. So we need to be fast. Sonography, visual medicine, no comment. We will assess mechanism or origin without arrogance. We take what can help us with pragmatism. Severe shock, a shock is deadly, so a severe shock is more than deadly. And of indistinct cause, do not lose time with ultrasound if you know where the cardiac arrest comes from, of course. So it makes a strange acronym, SISAMOSIC, which is a bit long. So we will cut Sesame, etc., or SIC, Sesame Protocol. If nobody minds, I would love to get rid of this thing downstairs that prevents me to see my screen. It's dramatic. The Sesame Protocol is a fast protocol, a whole body scanning, focused, of course, for finding reversible causes, of course. 3 minutes is long, and we can devote a few seconds for thinking why if this patient is in cardiac arrest. So we have a brain, and you know that a massage is good, but is bad. Also for the ribs, of plenty of things. Epinephrine is good and is bad. Brain hypoxia, thrombogenic effects. When you have an obstructive cause, you can make the massage during hours. You will never succeed. And the holistic tool that can show immediately an obstructive cause exists. The Sesame Protocol is a holistic approach. What does SURF mean by holistic? Everything must work together for the logic. This is what means the word holistic. The probe, the application, the machine. Which machine? Of course, we will need. There is no way to get rid of the bar below it. Whew. Okay, I give up. I give up because I cannot see my screen. The machine must be small. Since 1982, we had machines that are as large as the laptops that you all use every day in the world. Since 1992, you have a machine that is smaller than the laptops of today. And so it was not necessary to wait for the revolution of the laptops because we had it many years before and better, as you will see. Please listen just and you will see. This machine starts on in 7 seconds. This old Hitachi of 1992, 7 seconds, the fastest machine in the world, from zero, of course. In a congress, you are very confident. In the real life, you are stressed, you are tired, there is a pressure. The machine should help us and not confuse us. So in our world, at start on, we have, and in this machine, we don't have any filter, no harmonics, no Doppler, not army of buttons. And we defined a setting for cardiac arrest. When we switch on the machine, it is in the setting cardiac arrest. And for instance, one point, we have a 8 centimeter depth at start on. And we have saved hundreds, thousands of neurons, thanks to this very simple detail. Which probe? We use one universal probe. We make a whole body fast protocol. We have no time to change the probes. This universal probe, singular, will work better than all the traditional probes. Never we feel limited by the image resolution, by the ergonomy. It's a very mysterious story. Look at these images. They are taken with my old Hitachi and my unique probe. And you can see upstairs a beautiful jugular vein, a beautiful heart, a beautiful gallbladder, a beautiful, now downstairs from left to right, a beautiful optic nerve, a beautiful lung, inferior caval vein, maxillary sinus, all this with the same microconvex probe. And you will see here, it is a heart. It is a cardiac probe. The answer is no. Here we can see a beautiful catheter in a beautiful jugular vein. Is it a vascular probe? No, it is still this universal probe. Can we see a drama in the Douglas pouch of this young lady? Is it an abdominal probe? No, 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 no. And here we look at the lung. Is it a lung? Yes or no? And which probe? We use always the same universal microconvex probe. It's a very strange story that regards medicine. If you find that the year 1992 is ridiculous, I can give you a machine of today, which will show you with the same microconvex probe, the lung, here a very diseased lung, you recognize, a heart, okay, with a good systolic function and no pericardial effusion, or this jugular vein, which appears completely thrombosed. So we have the same information as we had in 1992. Look upstairs, this is my world. Look, my world. Look downstairs, this is what I see when I open an article. This is the quality of here, the cardiac probes. We do not accept this image quality. Why is this probe holistic? We did the scientific assessment. This diagram indicates the severity and the frequency of the disease. So lung come first. And you can see that the cardiac probe can see a little bit of the lung, a lot of the heart, but when there is no window, they are blind, a little bit of the veins, a little bit of the abdomen, a little of the head procedures. The abdominal probe can see a bit more of the lung, a bit of the heart, the veins, a bit of the abdomen, because when you have an abdomen, plenty of this kind of a vision, this probe is much too large for no advantage. The vascular probe can see a little bit of the superficial lung, a little bit of the heart, a little bit of the veins. It cannot see the central veins, the inferior caval vein, the superior caval vein, the subclavian vein also. So this probe is not a vascular probe. It is linear, but not really vascular. Our microconvex probe have this balanced landscape, able to see quite all with the same limitations for the heart. When there is no window, there is no window. The winner is from far with 0.29, the vascular probe that I never use. And you can see downstairs right that our microconvex probe has 0.92. This is a logarithmic approach, but we will save time. I have no idea which time is it because I put my timing in the bottom of my screen. It's a bit crazy. Well, we will try anyway. So we can see with that logarithmic diagram that all what is interesting in the critical care is in the scope of our microconvex probe. The vascular probe can see the first millimeter, but I don't care the first millimeter. I want to see from 0.6 to 17 centimeters. This makes me happy because I can see all the field of critical care. Here, it's an animal. It is too blurred. I recognize. I give a little better image quality, and we all recognize a little cat. I can improve the image quality. It will not change the diagnosis. It will be more pleasant, and I work with the 300 kilo-octet quality. Most of the time, 99%, and sometimes we have to ask for something different. That's exceptional. Another example, these letters nobody can read. We have to find a 5 letters word, the most holy word in the world. So I give a bit more image quality. Some people may begin to see, and here I think everybody begins to see clearly that we speak of the Bible. And of course, with a bit more money and a bit more processes and time, I can increase the image. But the image quality, you cannot see any change from a certain value. And this is exactly the same with ultrasound. You spend a lot of money for no advantage. There are plenty of combinations, but time is running. The universal microconvex probe solves the dilemma. This is the probe of the future for the critical care physician, and many 15 other disciplines, clinical disciplines, look out the poor imitations. Our probes, that is this one or this one that I have in my airborne missions, has a decent resolution. You have seen the image quality and a range from 0.6 to 17 centimeters, which is perfect in adults and even many children. The universal microconvex probe is the probe of after tomorrow. How about tomorrow and how about today? Doctors will tomorrow maybe go to the night shifts, and what shall we say to those who do not have the universal probe? Solution of SURF. Today, here and now, the best compromise in resolution is in the abdominal probe that we favor. The ergonomy is not at all good, but we favor. The cardiac probe is a better ergonomy, but the resolution is a disaster. And the linear probes, the ergonomy is a disaster, and the first millimeters are beautiful, but we need to see deeper. So it is not the probe that we use, never. A solution for tomorrow is to sell a cardiac probe and a vascular probe. And for this money, you can buy microconvex probes that are not completely holistic because they don't have a good depth. It is a probe from General Electric. Yes. If you keep the abdominal, you can change the probes all the time, but only 2 probes instead of 3. So it's a bit better. The Sesame Protocol is not only medical, it's also an ergonomic exercise. Our machine, this is our Hitachi, is always by default configuring Sesame. That is, the electricity, you don't see it in this image, is in front. So you do not search for it, you have it, you plug. The machine is ready for the Sesame configuration, that is no filter, depth 8 centimeters, and some more. And the probe, as you can see, is at the middle, waiting to be used. There is no choice, no painful choice to do. Okay, so I am late. I can see my number here. So for avoiding to spend hours with inefficient resuscitation, we will see the step 0. We will assume that the patient benefits from a ventilation. This is absolutely in the protocol. By any means, it can be mouse to mouse, it can be with this machine, it can be the most elegant if you are accustomed intubation. Why? Apart from giving oxygen to the patient, which is maybe a good idea, I know that there are guidelines which say it is forbidden to ventilate the cardiac arrest. Why? First, because it is a guideline, so it will change next year. See, you will see, it will change. But the most important reason, it is a very basic reason, we do not accept to see a young patient in cardiac arrest dying from a stupid pneumothorax. That is the main reason. The Sesame Protocol considers the most reversible causes, and it will impact not only the ultrasound, but also the technique of the initial management of cardiac arrest. So be prepared to make any ventilation to the patient. Because the Sesame Protocol begins with the lung. The heart is visited, but in the position 5. We need to give a minimal life to the lung, the most vital organ as we know. So we begin, I don't lose time, by the lung in spite of what is written in the textbooks. Why the lung first? The reason number 1, I don't want to die or to see my family dying from a pneumothorax. It's not acceptable. The reason number 2, the window at the lung is very generous. Unlike the heart, you put the probe, you have an image. Reason number 3, you can detect here the A' profile in 2 seconds. No lung sliding at all, stratosphere side. Point number 4, when I see A lines, if I follow the false protocol, I can ask to my nurse to give immediate fluid therapy. Point number 5, the patient is in quiet breathing, very quiet, because the patient is in cardiac arrest. Only you make the lung live, and this is the perfect condition for diagnosing pneumothorax. That is quiet breathing. Point number 6, it is logical to search for a pneumothorax before the rib fractures create a pneumothorax. That's just basic logic. So it is written downstairs, I remember, because these are my slides. If people disagree, they must show to me very strong arguments. Well, when time, pressure, and stress prevents us to think efficiently, the lung before the heart is the first step, that is the first difference of the Sesame Protocol. You can see the decision tree, lung before heart. Each second is optimized in this decision tree. You can see at the second, and we are generous for the beginners, but we rule out immediately pneumothorax, and then we will see. I don't comment. Last peculiarity of the Sesame Protocol, it can be done at the point of care. And I say now into brackets because 20 years ago, I had this fantastic Tringa machine That was a great tool that was always with me. This is my second profession. I make airborne missions. In sometimes these are strange planes. It's a Piaggio 180, and we have the equipment always. That's the machine that I use for my missions. But the community must absolutely accept the concept of the unique probe, because you must optimize the weight of your equipment and the volume of your equipment. So here, there is no space for having 100 probes. A new warning, and it is a reminder, the Sesame Protocol must not be done if you know the origin of the cardiac arrest. If you don't, if you are like me, always blind in this very stressful question, let us see the Sesame Protocol. Grade 1 is for the pneumothorax, the lung before the heart. So real-time movie first, cardiac arrest. So step 0, step -1, no arrhythmia. Step 0, giving a ventilation by any means. And now I focus on the lungs. And I see the left lung. Okay, the ventilation is efficient. There is no pneumothorax. Right lung. Oh, there is a great anomaly. That's the A' profile. We can see the typical initial pattern of the pneumothorax, which is fully sensitive, the A' profile. Pneumothorax is very likely. And so we see again that the Sesame protocol is a very fast protocol. So, but we will stop the action. So I don't see what is below. Yes, it is one of the articles dealing with Sesame protocol. So I always use this machine or equivalent of today, but this one is available since last century. One probe. I switch on the machine in 7 seconds, so just the time to take this probe. There is no setting to do. It is already done, and the machine is completely easy to buy, very inexpensive. So action, so lung, okay, lung sliding, fine. I took 2 seconds for saying, okay, lung sliding, fine. But this assumes, first, that we need to have a probe which is perfect for the lung and which must go just after to the veins, the abdomen, and the heart. It assumes that by starting up the machine at start on, there is the setting of the Sesame protocol. That is no filter, no persistence, all these filters which confuse, which pollute, which complicate lung ultrasound. You can put them when you have time, but here you have no time. So the machine is ready for you. We need an adapted nomology that is immediate access to 3 functions that I use in daily life, but in the Sesame protocol, even 0 button, the machine is ready. I just have to take my probe and scan in the 4 first steps. And we need also the, I say, sub-longitudinal approach, that is, in scientific words, in the rib short axis view, to have immediately the bet sign in any circumstances, the murciélago sign in Spanish, I think, for immediately knowing where is the lung, where is the pleural line, where is the visceral pleura. And now we can see all the conditions are done for making the immediate diagnosis of the A' profile. That is, plus a clinical sign, which is cardiac arrest, that's not nothing, makes you think that if you want to save this life, you must take any cutter and do the work. So again, the A' profile with complete abolition of lung sliding, generating the stratosphere sign, and the A-line sign, which is always present, never B-lines or consolidations. This is the A prime profile. Fully sensitive to pneumothorax. This is a lung point that was posterior, but I don't ask young doctors to search for a lung point in a cardiac arrest. This is, to simplify, optional. Just look at the beauty of this 1992 machine and this universal probe. Just take a look and make your opinion. That was grade 1 cardiac arrest due to a gas tamponade, lung before heart in cardiac arrest. Grade 2, pulmonary embolism. We will not see the heart. We will see the veins before. No pneumothorax to the left and to the right. In this patient, there is no pneumothorax. So the resuscitation will be more complicated. We go at this area a bit above the patella, which is called the V point in the blue protocol. It will be published, I hope, one day. And when you scan at this area, forget this because time is running, you make a maneuver with your free hand and you can see none of these vessel collapses. So the vein is thrombosed. This happens in half cases of massive pulmonary embolism. Half of the cases, 47. And why the veins before the heart in the Sesame Protocol? First, because the vein is on-off. Here you can see there is a very scary thrombosis. Yes, no, yes. The right ventricle, there is sometimes no window, or sometimes you are in the very scary gray zone. You cannot use your echocardiographic data. Second, the venous window makes no issue, unlike the cardiac windows that are never sure to be present. Third, we do not need to interrupt the cardiac massage. And fourth, we remind to the youngest that the specificity of the blue protocol for pulmonary embolism is 99%. I would love to hear the accuracy of echocardiography. I'm not sure it is 99. So with lungs and veins, you have already quite the diagnosis. So this was a grade 2 cardiac arrest likely following pulmonary embolism. But when I see this kind of thrombosis, I treat veins before heart in cardiac arrest. Grade 3, hypovolemic arrest. Oh, we will scan the abdomen before the heart. Look why. We have another patient. I can see there is lung sliding. I can see also, this is the A profile. I keep it in my head, or I can even use my mouse to say to somebody, give fluid, massive fluid. To the right, we have the same A profile. That means if you follow the false protocol, clearance for immediate fluid therapy. That was published, so you just have to read. And then we scan the V point. That's how we called it in the blue protocol. Okay, so the vein can be collapsed easily. There is no thrombosis, but it does not rule out the diagnosis of pulmonary embolism. What do we do? Well, you can do like any doctor, that is, look at the heart. Why not? But if you choose this option, you make a travel. And during this travel of the probe in the direction of the heart, we will make a short stop exactly here in the abdomen. The abdomen is on the way. Wow. Okay. Fluid. It must be blood, plenty of blood in the sesame pouch. Okay. That's a hypovolemic arrest. So the fluid therapy was given already, must be reinforced, and blood as soon as possible and surgery, etc. You can save this patient. It was found after 15 seconds of ultrasound. So we can say that Sesame Protocol is a really fast protocol. I say that. And you can see that ultrasound is a great tool, but I'm sure you are convinced you can see fluids. So definitely ultrasound had to be in our hands and not in the radiology department. Definitely. I go fast. Please see the creation of SURF, that is the sesame pouch, that we have taken the liberty to put it at the zone number 2 of the lung ultrasound international consensus conference, because in the zone number 2 you will see the image at the right, that is the liver, the abdomen. You are from lung in the abdomen when you are in zone 2. Okay, so let's do pragmatic things. I can see the liver, the kidney. This is with the 1982 machine, the ADR 4000. I can see the sesame pouch that is anteriorly faster than the Morrison pouch. It's not an opinion. You can make a study. It's immediate. You put the probe and you can see between the wall and the liver, there is something, fluid. And you know, there is a lot of fluid. That was a cardiac arrest due to peritoneal hemorrhage. It can be massive. Elsewhere, GI tract, pleura, can be several small sites in trauma. We know that the patient had a clearance for fluid therapy initially with the A profile. Here I give an example of blood in the GI tract, etc., etc. So with the fluid therapy with a bit of epinephrine, you succeed to ROSC the patient. The heart beats again, but you would like massive fluid therapy through subclavian venous cannulation, and you want it fast. Should you use a linear probe? Nobody uses linear probes for the subclavian vein. They fear to make a pneumothorax, and I say, but with ultrasound, making a pneumothorax is not possible. The problem of this probe is that it is linear, but we are not linear. Why do we apply linear objects to non-linear organisms? It is not logical. So this is how we do with our universal probe. It's a fictitious procedure, as you can see. First, we go in the short axis of the infraclavicular subclavian vein, and we can see, okay, artery, vein, the vein is compressible, okay, fine. Now we just have to insert the probe in the long axis rotation. Long axis. And then we take the equipment. So I do fast, it is a fictitious procedure. You just have to put the needle in front of the landmark. There is no out of plane, I don't know what is this. You can see this completely standard normal needle perfectly seen in this parenchyma. Why do they make sophisticated needles? There is no need for this. This is the most simple equipment in the planet. And the subclavian infraclavicular approach, we did that since 1989, and the SURF revendicates to have given the idea of cannulating the veins of critically ill patients. It is in this article, even if people think that Lichtenstein is lung ultrasound. It's a mistake. And they made an international consensus conference with 65 statements. And for us, it is strange. It's not logical. And our explanation, they do not use the logical probe. Well, so in the Sesame protocol, the abdomen comes before the heart in cardiac arrest. Next step, the grade 4. We did not rule out pulmonary embolism, so we will see the heart. Oh, just before, excuse me. Before looking at the heart, we will look at the peri-heart. That is, around the heart, we will search for a pericardial tamponade, as you always do, I suppose. And the pericardium is completely dissociated from the heart at surf for practical and also life-saving reasons. First, of 4 good reasons, it's not difficult to see that there is not one heart, but 2. Very simple. It should be the beginning of critical ultrasound. And the window is usually present because the pericardial effusion makes the window. The cause is usually reversible. So you treat, the patient lives again. It's a pleasure. And it is a superficial structure, so the therapy is rather easy. So Sesame protocol in this other patient, I can see there is lung sliding. There is lung sliding. Okay, no pneumothorax. The vein at the V point is okay, so maybe there is a pulmonary embolism. We make a stop at the abdomen. Here, there is no blood. And we look now at the peri-heart. Oh, no problem here. Everybody can see, even students, that the heart is surrounded by a huge effusion. And you can also say, but it is a bit redundant, that the right cavities are collapsed. So pericardial tamponade, there is no question. You have just to make the therapy. And you will see that for extremely urgent pericardiocentesis, the SURF gives you a holistic procedure. And this is a critical and holistic detail. You have in the hands a probe that will detect the tamponade and the needle that we will insert immediately. And you will see the needle at the right of the image. And this is the complete opposite of echocardiography, when they have to make sophisticated maneuvers because they cannot see the needle with these probes. So the microconvex probe impacts the on-site management, definitely. So a cardiac arrest following pericardial tamponade, and let's not lose time. Time is running. So in the Sesame protocol, the peri-heart comes before the heart. Well, now, oh, we are very late. The heart. Now we will take a look to the heart. So the very heart is on focus. Now, so lung sliding, the vein collapses, okay. The abdomen is dry. The pericardium, and only the pericardium, is dry. So we will see the heart. Oh, just before, a prayer, a short prayer of 2 seconds, give me a cardiac window, because we did not need to make this prayer before. So here it is necessary, but it will be a pragmatic prayer. And during these 2 seconds, you will touch for the first time the machine for increasing the depth from 8 to 14 centimeters to look the whole of the heart. And now, what shall we see? I look at the time. I will stop at 45. Wow, no cardiac window, panic aboard, bad luck for the patient. We have to play guesses again. That is coming back to the dark ages, guessing, is it not? Maybe you will have an asystole. Spectacular. But are you happy for the prognosis of the patient? I don't insist. Maybe you will see kissing walls of usually hypovolemic arrest. This is déjà vu. It was seen in the step 1 and 3 of the Sesame Protocol. It is redundant. You have treated the patient already. Maybe you will see a dancing heart of a pericardial tamponade. That is déjà vu in the step 4 of the Sesame Protocol. Maybe you will see a dilated right ventricle of usually pulmonary embolism. Déjà vu, déjà vu, déjà vu, déjà vu. It was in step 1 and 2 of the Sesame Protocol with this 99% specificity. But I admit when you do not see the DVT, there is a good reason to see the right ventricle. So if we have only 30 seconds, I would say no pneumothorax. I would say no deep venous thrombosis. I would say no fluid in the sesame pouch. I would say no pericardial effusion. So here we have to see at the very heart. And this is the philosophy of the Sesame Protocol. So I don't insist because time is running too much. There is no sensitivity nor specificity of the Sesame Protocol because everything has been validated and the question makes no sense. So the 45 minutes are finished. So I will give the microphone. I did not finish my lecture on time because I was stressed by the poor conditions of Zoom. And it is exactly the same when you do not have the correct ultrasound machine. You make mistakes. So I give the antenna.
Thank you, Dr. Lichtenstein, for your presentation. Although time, yeah, it has been a trouble. If there is something more you want to add, it's okay. You can finish. Or if not, we also have some questions if you would like to answer them.
Yes, with pleasure.
Okay. First, so one of the questions that we have from our participants is, what are some of the factors during cardiac arrest that were foreseen before you established the Sesame Protocol?
Can you ask the question again a bit slowly?
For sure. What are some factors during cardiac arrest that were foreseen or ignored before you established the Sesame Protocol?
Okay, I understand. This is an elegant question. First, the lung. The lung was not supposed to exist. So initially, you had to do the work for just not going to jail by using ultrasound. If you use ultrasound just for looking things that do not generate a therapeutic procedure, you lose time. And people can say to you, instead of playing, you should take care of the patient and do your work of doctor. And you could have medical legal troubles. So I had to make the field solid first. What was foreseen is the pericardial tamponade. The blood in the abdomen is something that everyone knows. Maybe the venous thrombosis in the V point was something a bit more from the Blue Protocol. But this is a visual medicine. So the factor was, of course, to look at the patient. I hope I answered. The lung was the main factor, I think.
Yeah, for sure. And another question that we have for you is, what do you think are the main difficulties of applying the Sesame Protocol or the main limitations?
The machine and the probe. Sure. I travel around the world. I always see machines that are, to the opinion of SURF, not really suitable. Of course, you can look at the heart, only at the heart, but you deprive yourself or to look the rest, or you change the probes and it is not very good for the brain. And all the buttons and the settings that I can see, these are the limitations.
Okay, and do you think that in the future, since you can also acquire, and I've seen these machines where you can acquire an echo transductor that you can connect to your phone, do you think that this will allow that a Sesame protocol will be established all around the world and between all the different physicians, or what is the future that you see for the Sesame protocol?
Thank you for this question. A machine that you can put in your pocket, as the ones I could see, very strangely, the manufacturers, they know my name, but they did not ask me, Lichtenstein, what do you think of our machines? And the answer is, it is not because it is a pocket machine that it is good. Far from that. So I think that any doctor should have a machine that follows with in a trolley, for instance. And people in the street will not, if they are not doctors, use ultrasound. So I think it will. We will have to wait for the medical teams, the mobile teams coming, and they will have ultrasound. There are more portable machines than others. I'm not sure I answered the question. Maybe it's 2 o'clock in my night.
No,
Maybe.
No, it has been answered, and I believe that it's true that we have still need to improve these machines that are portable, and it will allow in the future to, I hope, to establish the Sesame protocol everywhere, and that we can even consider it here in Latin America, because it will
Everywhere.
allow it will allow a visualization and a change of medicine that we have known so far, not just to see the blood pressure, the vital signs, but also to visualize in a different setting all the patient itself.
Yes, but let me add, you speak of blood pressure, but we can also add the traditional ultrasound, which is much better than nothing. But when you are accustomed to look at the image quality, do you see my screen, my last slide? When you are accustomed to this quality, with the other machines, you feel a bit disappointed.
It's true.
So you can add ultrasound to the list.
Well, thank you, Dr. Lichtenstein, for your presentation. It was very clear, and as I told you before, I hope in the future that the Sesame protocol gets to be established everywhere and it can be useful for everyone. Thank you again for your presentation, and I hope you have a safe flight.
Thank you. I hope the next time I will go to Ecuador and shake your hand.
For sure, you're more than invited to come here in the next Congress. It will be awesome to see the progress of the Sesame protocol and to talk with you about other topics. Thank you so much.
Thank you. Thank you.